Hi everyone, this is Neil Wright, consultant audiologist and director of ClearWax. Thank you for joining me in my latest video using the iClearScope endoscope. This is actually of a patient who attended today. They attend every year around this same time, pre-Christmas, and the procedure was performed in both ears, but I'm just showing you their left ear in this video, and I will upload the video on the right ear perhaps tomorrow. And this patient, bless her, every time she comes, she always leaves by giving me a big hug, which is a great feeling, obviously, when you know you've helped someone. And they do also follow me on Facebook, and they joked that they wanted to come sooner, but because I was away in Australia, they had to delay it. So the wax in both ears, it's a completely different consistency. They do suffer from a bit of otitis externa, more laterally. We've kind of referred them to their GP in the past, and it's a lot better than it used to be, certainly. And they used to also suffer from otitis externa of the ear canal. Now the ear canal looks a lot better than previous visits as well. So now this patient, and I'm sure they don't mind me saying, they were in the past guilty of using cotton buds or Q-tips as they're known across the pond in the States, and you can tell straight away because especially with this consistency of wax, you get an indentation on the surface. But they were good today. They didn't use it, but it's still quite a complex procedure, and it's to do with the consistency of the ear canal, and also because it's quite a narrow ear. So this consistency of wax, it's sticky, it's stretchy, it's almost a bit like chewing gum, particularly the bit at the end that we remove out of the anterior recess, and it was quite tricky, which you'll see. Now I've just put some oil in there, so it's got a bit blurry. I've just kind of mopped up some of the excess oil before going back in, and just hoping the oil kind of just binds the wax together a bit better. Just gives a bit of loosens any skin adhesions that are on the periphery. And just this is probably about half the way in, probably 2/3 now, sorry. And so far it's coming away okay, but I know what's ahead because obviously I've treated this patient a few times, so I kind of know what to expect when we get to the eardrum. And I was just waiting for that moment where it gets really tricky, and we're almost there. You can see this wax is not suctioning as well. There's quite a lot of dead skin there as well, which is kind of macerated within the wax, so, and that can sometimes make it sticky. Now we can see some of the eardrum, that blue tinge. Just a bit of oil there, so I'm just going to mop up the entrance. And I think at the moment I'm using a 16 gauge, which is a smaller suction tip. It's kind of what I refer to as a medium suction tip. But it looks like a 14 gauge, which is the standard size because it's filling up most of the ear. And on the left-hand side, or just below the suction tip, now this patient's head's orientated slightly forward, so the real kind of orientation would be 90 degrees to the right. So although below the suction tip, that looks like the bottom of the ear canal, it's not. It's the anterior canal wall, the front part. And we're very close to it with the suction tip, and just beyond that bony part there, the ear canal widens again. And this is horrible stuff to remove. It's embedded on the eardrum, and there's just very little margin for error here, because the last thing I want to do is touch that bone. And I think unless you've experienced it yourself, it's hard to explain. It is painful. It's very short-lived acute pain, and the best analogy I can give is if you accidentally bump your shin against the side of a door, for example, or chair, and just trying to go into the inferior recess. Although it looks to the right hand side of the ear canal, this is the basin of the ear canal right in front of the eardrum. And if you're not careful, you can actually inadvertently push this up against the eardrum more. You can smother it because of the consistency. So I'm just trying to hover over it. Now there's a bit to the top part of the ear canal, which looks like it's on the left hand side, that I managed to grab onto and take it off the canal. You'll see that in a moment, and then Fortunately, it did come away in a plug. I'm just trying to generate some suction power, and I think I've now gone to the 17 gauge because obviously the ear is quite narrow. Just needed that smaller suction tip not to push up against the canal wall. Now so just to the right of the suction tip, you can see it's a little bubble there. That's the posterior superior quadrant. So that part of the eardrum, the middle layer, the fibrous layer, the fibrous tissue is not as well arranged and organized as the rest of the eardrum. Now, that part of the eardrum is actually thicker than the main body of the eardrum, but because the fibrous tissue is not arranged in an organized manner like the main body of the eardrum, it's a bit more elastic. So if you blow your nose, for example, which is what the patient's done here, you can get air that enters that part of the eardrum and pushes it outwards. Now, initially I thought it was some oil, but it's not. It's the eardrum just bulging in that region. And I once had a patient in that exact same region. It was so inflated. It was like someone like you got a chewing gum and you're blowing up the chewing gum, and it was going to pop at any time. So it was a few years ago. I still remember the case, and I was a bit worried because it was so enlarged. And we referred to ENT, and by the time they got there, it had resolved itself. I did give the patient an image so they can show the ENT, but all was good in the end. So I managed to bring that away. Just gonna have another look at the eardrum. Well, I hope you enjoyed that video, guys. Take care, keep well, speak soon. Bye.